Next, about this Parkinsonism disease, uh, we were discussing this pathophysiology, that how various areas are involved, what exactly things are there. So if we see, these are the structures which are involved. That is, three important parts are there in corpus striatum, that is caudate nucleus, putamen, globus pallidus, and it is in a constant touch with various nearby surrounding areas, including thalamus, cortex, midbrain, etc. And these areas, they are playing very important role in fine tuning of various impulses, which are particularly related to the activities including muscle control. Let us see more depth into it. So this is what the normal wire diagram we can say, that cerebral cortex is receiving input through thalamus, and thalamus is receiving input through substantia nigra, globus pallidus, etc. So, and these all fine control is very important, as I told you earlier, like proprioception and all continuous information about the tissues. It's very important. The muscle tone is important whenever we are doing any kind of activities related to muscle. Then every time our muscle positions, muscle characteristics are taken into consideration by cerebral cortex, because cerebral cortex or that particular area is constantly receiving sensory inputs about that. So what is muscle tone, whether muscles are having more tone, less tone, which muscle has to be contracted, which has to be relaxed, because when we are doing any kind of movement, we have got two types of activities: contraction of some muscles and relaxation of another muscle. Or okay, so this type of all activities are very important. This fine tuning is very important, and for that these constant inputs are there, and that constant inputs are processed into the motor one. So here we can see that the cerebral cortex is having the excitatory input through glutamate one. We have seen that glutamate, NMDA, these are excitatory type of activity showing. And dopamine has different type of receptor, D1, D2, D3, D4, etc. And the odd one are there, D1, D3, D5, these all are excitatory, while D2, D4 are inhibitory. These are all information we have from our earlier knowledge about dopaminergic receptors. Now what happens is, there is one area, we call it as a substantia nigra pars compata. So this is the substantia nigra, and this substantia nigra has got the nucleus or centers for various control, and they are having this dopaminergic neuron. So dopamine is released. This dopamine goes to corpus striatum. This corpus striatum is having variety of receptors and variety of neurons having different kind of neurotransmitters and different receptors for these neurotransmitters. So dopamine can act here on both, that is D1, which is excitatory, and D2, which is inhibitory. When it acts on D1 receptor, so it causes the action of the GABAergic one, so which is inhibitory in nature, while here it will, D2 will cause, again it will also cause GABA, but again second will be inhibitory, and later it will be converted into the glutaminergic, that is excitatory one. And from these two signal, this is a direct pathway, because from D1 to direct globus pallidus and substantia nigra pars reticulata, PR here is a pars reticulata, and GPI is a globus pallidus. So interna and externa, these are the areas of the globus pallidus. So this is a globus pallidus which is externa, and here substantia nigra pars reticulata. So these are two structures, substantia nigra pars compata, substantia nigra pars reticulata. These are actually very close to each other, but see, the mechanism is, it goes far away. Far away means not very far away, but yes, it goes to the another portion of the or another area of the CNS, that is from substantia nigra it goes to corpus striatum, and from corpus striatum it comes back to substantia nigra. Only the areas are different. In earlier it was substantia nigra pars compacta, now it is coming to substantia nigra pars reticulata. Now once these are coming, you can see the difference is here. First is D2, which is inhibitory, it will inhibit the GABA. So there will be decrease in the inhibition, and because of this decrease in the inhibition, again it will be decrease here, and accordingly it will affect the glutaminergic activities. Here directly it is causing increase in the GABA, so GABA is inhibitory, so here it will inhibit. So that way one is excitatory, one is inhibitory, and from that it will carry signals through ventrolateral portion of the ventroantral or ventrolateral portion of the thalamus, and that will give signals to cerebral cortex, from which it will give again a motor signal to spinal cord and brainstem. So this motor signal will cause muscle contractions. So this is how the activities are there. Now what happens, this is the normal activity, this is the normal, this one. What happens is, we shall see again the mechanism why this is happening. We have seen earlier the basic thing is, what happens is the dopaminergic neurons in the substantia nigra pars compacta, here we can see these purple color signs. So this purple colored sign will show that here this dopaminergic neurons which are there, this dopaminergic neurons are damaged. We shall see the mechanism, as I told you, whether these Levy bodies and all other structure are responsible and how they can be doing, or what can be the proposed hypothesis for that. So these are doing, because of that it will cause this increase in the D1 activity but decrease in this, and later you can see this red color. So this red color one or this buff color one, so this loss of dopaminergic input to this corpus striatum will have differential effect into two outflow pathway. We have seen D1 is a direct pathway and D2 is a indirect pathway. So the direct pathway to this substantia nigra pars compacta, which one is direct? Where D1 is involved. This first one is a okay, and the second one is a D2. This is an indirect pathway. Why indirect? Because D2 to globus pallidus externa to substantia subthalamic nucleus. So these three portions are involved, and then it reaches to globus pallidus interna. So therefore we call it as a indirect pathway, because it has got so many steps in between. So the direct pathway, it is a less active, while the activity in the indirect pathway is increased, which are in rate, and the net effect that the neuron in the substantia nigra pars reticulata and globus pallidus interna, they will become more active. It will lead to increase in the inhibition increase in the inhibition, that means more GABAergic, this one, that will become there. It will become more active, leads to increased inhibition at the this ventroantral, ventrolateral thalamus, and therefore the reduced excitatory input to, because more negative sign will be there, it will cause more depression, and or more inhibitory type of impulses are there. So net effect will be there, that is reduced excitatory input to the cortex. So this reduced excitatory, and therefore, so this purplish color indicates the primary pathways, and there are the reduction in the activity, there will be decrease in the activity, while the dark color are there, that will show the increase in the activity. Even if it is inhibitory activity, still increase, that means more inhibition will be there. So this is the basic mechanism that takes place. This basic mechanism is so far hypothesized, because nobody knows exactly in CNS what is happening. These are all indirect relations, measurement of various neurotransmitter, etc., and by this way these are elucidated. These are not obtained directly or which are confirmed directly. Now, there are some researches are there that show that what are various reasons. One of the important research shows that Levy bodies, they are abnormal aggregates of protein that develop inside the nerve cell, particularly in the Parkinsonism disease and some other CNS diseases. They are identified under the microscope when histology is performed. It is composed of the protein alpha synuclein. We have seen synuclein earlier, if you remember the Bragg postulates, and this is associated with the proteins like ubiquitin, neurofilament protein, and alpha B crystalline. Some tau proteins may also be present. Tau protein have more importance role in Alzheimer's, when we shall see later. So there are various genes which are, we have seen that it may be genetic earlier when we were seeing the etiology or the causes, what can be the causes. So in that we have seen majority of cases we see that it can be a genetic one. So how genetic? So the important link which has been found with the Parkinsonism and the people which are having more chances or having Parkinsonism or not having Parkinsonism is alpha synuclein. It is also known as a SNCA protein. That is, in human it is encoded by the gene that is called as the SNCA gene. It is a synuclein protein of unknown function. Function is not known very well. It is making of around 1% of all protein in the cytosol, that is whatsoever protein, number of proteins are present in cytosol. If we make together list of it, so it is, or amount of it, then it is 1%. It is predominantly expressed in the neocortex, hippocampus, substantia nigra, thalamus, cerebellum, and predominantly neuronal protein, but it can also be found in the neuroglial cells. It is alpha-synuclein is a synaptin protein present in large amounts in the normal brain. Mutations occur in the rare types of hereditary Parkinsonism disease, and it is believed that this mutation causes the protein resistance to degradation within the cell, and it piles up, and it is then makes the Levy bodies, and it is thought that it is believed that the normal function of alpha synuclein is related to the synaptic vessel recycling. That synaptic vessels are there, if you know, if you remember adrenergic mechanism, which is very nicely taught many a time, that how adrenaline is synthesized and then it is kept into vesicles, and whenever again the impulses come, the calcium comes in, and because of that the synaptic vesicle is causing exocytosis. This is whole mechanism very nicely elucidated in whatsoever pharmacology book you go through. So this is there, and then this synaptic vesicle which is there, which has released the neurotransmitter in the synapse, will be recycled. So what is expected here, that what is the role of synuclein is, it is helping in the synaptic vesicle recycling, and if the synaptic vesicle is recycled, then it will be again formed, and after formation of it, the neurotransmitter is put into synaptic vesicle. Now what is the importance of synaptic vesicle? That whenever synaptic vesicle is present, if you remember earlier, the action of reserpine, you might have studied earlier. So this synaptic vesicle are very, very important, because in that synaptic end terminus or synaptic bulb, the enzymes like monoamino oxidase are also present, and if the neurotransmitter is not getting inside the synaptic vesicle, it will be metabolized by this MAO. So here same thing, if you apply same thing over here, because dopaminergic neurons is also catecholinergic, dopamine is also catecholamine. Only thing is when dopamine is having structural modification, if you know decarboxylases, dopamine decarboxylases, and then it will be converted into adrenaline. So basically structurally almost very close to adrenaline, same mechanism is followed. So because of that, when this recycling is not there, the vesicular storage of dopamine is impaired. If the vesicular storage is impaired, that means it will remain in a free form. If it remain in a free form, then the free concentration means which is not present in the synaptic vesicle, that will increase in the cytosol there, and this will be easily available for metabolism by MAO. MAO causes monoamino oxidases. As its name indicates, it causes oxidation. Because of this oxidation, it will produce reactive oxygen species. This reactive oxygen species will be injurious to that own neuron, and thus they will cause the destruction of the neuron. Because of that, the dopaminergic neurons in the this substantia nigra pars compacta, as we have seen earlier, they will be damaged, and because of their damage, there will be reduction in the dopamine, and because of the reduction in the dopamine, there will be less action on that dopaminergic receptors, and thus the next subsequent cycles will be impaired. So this is how it is explained. We will not go into that more detail, that how these are making, how this synuclein is acting, how it is affected, and how it is converted into Levy bodies, and because of that, what are various impact it may cause. We do not want to go into this much details, because this is just information about how they can be playing important role. So it is interacting with the dopaminergic transporters. It is affecting the ligase enzymes, phospholipase, D1 enzyme, syncape, and tau proteins. So with that, all this, it is interactions. Then one more type of we can say culprit is known, that is LRRK2, that is leucine-rich repeat kinase 2 is also known as LRRK2, it is also known as a dardarine. It is a protein member of the leucine-rich repeat kinase family. So kinases are the enzymes. We know protein kinases. They are rich in leucine, so we will call it as a repeat kinase, leucine-rich repeat kinase family. And they are their mutation in the gene has been associated with the Parkinsonism disease. Then another type of activities are known, that is known as a serine threonine protein kinases. Those who are interested, or those who have studied genetics in detail last year, fourth year students. So if you remember it, this is one more class of enzymes. We call them as a serine threonine protein kinase. They are also called as a caspases, and they are the enzymes which are taking part in apoptosis. So this gene, that is PINK1, it is a mitochondrial enzyme, and in human it is encoded by PINK1 gene. It encodes serine threonine protein kinases that localize into mitochondria. It is thought to protect cells from stress-induced mitochondrial dysfunction. Mutation in this causes one form of autosomal recessive early onset of Parkinsonism disease. There are other genetic mutations are also responsible, or they are found, and there are many. There are many complications are there because of this Parkinsonism, and that is, it can cause sepsis, pneumonia, then fecal impaction, urinary tract infection, and they all should be suspected in Parkinsonism patient with a rapid deterioration, or even new Parkinsonism disease syndrome. So we can have various early complication. We have seen even it can be a simple constipation which is continuously occurring. Then altered mental status, confusion, sedation, dizziness, hallucination, delusions. We have seen psychosomatic or psychomotor syndrome. So these all complications are there, that the person will have this psychomotor syndrome also. Late complications will be motor fluctuations, dyskinesias, dystonias, freezing, falls, and these are all gradually increasing. Then behavioral neuropsychological syndromes, we have seen earlier also, we have seen this depression, sleep disorders, psychosis. Then autonomic disorders like problems in that is impotence, constipation, urinary incontinence, continence or retention. These are various hyperhidrosis. So these are various problems which are there. Then diagnosis, as we have seen, we have done it with various way. Most is symptomatic one. Then there is a rating scale, as you might have seen, those who have studied depression, schizophrenia, they know that we have got various scales to identify, to see that whether the, because we don't have any direct measurement, just like blood pressure or sugar, we cannot measure anything. So we need to have some questions and some observations, and on that basis the diagnosis has to be made. So this is what Unified Parkinsonism Disease Rating Scale, and many other such scales are available. Radio tracers is there for SPECT scanning machine, that is called as a DAT scan. This will be this is a specialized for diagnosing Parkinsonism disease, but it is only marketed in Europe. It can be difficult to diagnose accurately, particularly in early stages, because the important thing is, again, if you can fortunately diagnose it in early stages, then you can prevent all the subsequent. See, again, one more important term usually come whenever we discuss with the central nervous system problem, or these neurological problems, that most of these are not, they cannot brought back to the normalcy, but only what you can do is you can prevent the further degeneration. Means, suppose whatsoever degeneration, if there is a Parkinsonism disease and somebody can diagnose it in an early stage, and by that time if 10% degradation or degeneration has taken place of the neuron, then it cannot be reverted back, or it is almost impossible. In very, very remote or impossible cases, maybe there can be some recovery. But what is the benefit with the treatment is, yes, it will cause a decrease in the further, suppose the rate of degradation is, degeneration is there, that in first year 10%, in next year it will reach to 30%, in subsequent year it is reaching to 60%. And if we start the treatment, then what will happen? It may remain confined to 15% or 20% instead of going to 30%. And again, instead of going to 60% damage, it will remain confined to maybe from that 25% to 30%. So this is how you are preventing, this is how you are reducing it. The best responders, the person who responds the highest in that, the progression will be slowest in that, or minimal on that. So from 10 they can reach only to maybe 12 or 13, that is maximal. So they will remain almost in same stage, or very small change will be there, minute stage will be there, and continuously maybe in few years they will gradually go for very small incremental problem or degenerations. However, if treatment is not there, it is very fast, rapidly going, and it increases too much. One more hypothesis people say that, so whenever once the neuronal damage starts, then definitely as a feedback mechanism or as a physiological mechanism, more dopamine is released in that area. So because of release of more dopamine, what will happen again? More dopamine, more metabolism, more free radicals, and more damage. So this is how the cycle is there, and that is also very, very important. That is also to be considered. And even it is suspected that when we give treatment from outside and having L-Dopa like treatment, then again this care has to be maintained, because we have seen that dopamine itself is a culprit. When we say that the disease is because of, or disease, the symptoms are there because we say that there is a depletion of dopamine. But why there is a depletion of dopamine? Because it is against because of the dopamine only. The dopamine is depleted because of dopamine. Why? Because that dopamine, because of one or other reason, has metabolized, released free radicals, and resulted into own damage. So because of own damage, number of neurons which are able to release dopamine have reduced. Because of the reduction in these dopaminergic neurons, there are chances that some more dopamine is released from the available one, and it may cause toxicity to these. So this is how very tricky, very difficult situation to arrange for, to deal with. So early signs of symptoms of PD may be sometimes dismissed as the effect of normal aging, because we have seen that usually it happens in the people with more age, and then many times because of age you may be getting it. Very few and good doctors, those who are specialized, they can diagnose it in early stage, and if it is as I told you, if it is diagnosed in the early age, you can prevent a big loss which can be there in the next subsequent years. The doctor look for suppling of feet and lack of swing in the arm. These are important signs they can see while walking. It may be sometime request brain scan or laboratory test to rule out other diseases. CT, MRI, brain scan of people with PD usually appear to normal because it does not show any area is there, just like suppose there is a stroke or something is there. So one can see in CT that there is some infarct is there, some damage is there. So it can be seen, but here there is no direct damage. The neurons are getting damaged, which may not be seen in the CAT scan or MRI scans. So the person will go with the history of stiffness and slowing in the movement, tremor or shaking at rest, difficulty in getting out of chair or rolling over in the bed, frequent falls or tripping, difficulty in walking, memory loss. Memory loss means it is not as there in a dementia. That means difficulty in remembering the things, we can say, because we shall go later when we shall go for Alzheimer's or dementias. At that time we'll see that there is a very big loss of memory. Then shifting forward for posture into a stoop, speech changes, that is it becomes whispering like or rapid like speak. Then smaller hand lighting because muscle movement is affected. Slowness in performing activities of daily living, we call it as ADV, that is activity of daily living, will be affected. Then cyanoria and decrease in the sense of cells of smell. These are various activities it will cause. So these all activities will be affected, and this will be the signs. Cyanoria we have seen drooling earlier. That is, drooling means the excessive salivation. So these all activities we have seen, and these are the sign symptoms which are there. As I told you, what is the prognosis? I told you this, it is not considered to be a fatal disease by itself, but it progresses with the time. The average life expectancy of the patient is generally lower than the people who do not have the diseases. In the late stage of the disease, it may cause complications like choking, pneumonia, falls that can lead to death. The progression of symptom may take around 20 years or more. In some people, the disease progresses more quickly. There is no way to predict what the course the disease will take for an individual person. With appropriate treatment, most people with PD can live productive life for many years after diagnosis. I told you it cannot be reverted back whatsoever damage is there. Only we can slow down the damage. There are some indications that this Parkinsonism disease acquire resistance to the drug treatment by evolving into a Parkinsonism plus disorder. Usually Lewy body dementia can be there. Although transitions to progressive supranuclear palsy or multiple system can also be there. Other system to describing how the symptoms of PD will progress, these are called as a another scale is there, that is Hone and Yar scale. This is again one more scale is used, that is Unified Parkinsonism Disease Rating Scale, that is called as UPDRS. And these are complicated scales having multiple ratings that measures motor functions, mental function, behavior, mood and activities for daily living. Now where this scale will be more useful, we have seen Parkinsonism disease plus, where more this neurological or psychiatric symptoms are there, behavioral symptoms are there, in addition to the motor one. So this is it is that way complicated, but it can give all the idea about various functioning, how the mental functioning is there, how the behavior and mood and other activities functioning is there. So why we are doing, what are our objective to treat? The treatment objectives are to improve the gait pattern. We know gait is the walking style. to improve the speech. We have seen that whispering type of speech was there, breathing patterns like chest expansion, mobility, etc. Then to maintain the functional independence in the this having the normal daily problem is there, where the affecting the daily routine is affected, so they cannot do even normal daily activities. So in that we have to do it. Assist in psychological adjustment to new lifestyle. Then that is important, because otherwise they get frustrated with that, finding difficulties in motor activity, finding difficulties in cognition and all. So again psychological boost will be there. In therapy, at many times word is used that is called as a quality of life. You take this as a fourth year student, take this as a homework. Okay, what do you mean by what is the quality of life? Many research paper, many articles you will find about quality of life. Quality of life and Parkinsonism disease, quality of life and Alzheimer's disease, etc. So you just check. So here what I mean is our treatment will improve the quality of life of the people. The effort to improve the postural control and the standing balance, we have seen imbalances, falling chances are there, or even during bed sleeping, the difficulty in changing the posture. Then our treatment should improve the motor function and mobility. The upper extremity fine motor skill. What are the upper extremity fine motor skill? Writing, drawing, etc. Because of the tremors and all, these are all affected. So this can be there. Functional transfers are there. Swallowing can be affected in a later stage. That can be again. It should be checked. It should be improved. Cognitive. I told you memory is affected. Maybe not as it is affected in dementias, but yes, it is affected, and then it makes a problem. Recreational therapy should be given. The person is having a very somber mood, very the mood has fallen down, so this will help into it. Psychological intervention, or as we call it as cognitive behavioral therapy, will help in improvement of this. The nutrition, dietary factors, then family training, education, and the atrophy and muscle weakness, the agent which are causing, we can prevent it, we can improve the, or we can reduce the chances of contribution of other factors. So this multimodal treatment is there, and along with that, therefore we can have this group support people, the doctors or the experts, clinics can be there. Parkinsonism clinic is there, so there can be groups, and accordingly they can be trained. There can be physical therapy, there can be occupation therapy, speech therapy, recreational therapy, education, exercise, nutrition, surgery. These are in addition to the pharmacotherapy. Surgery again is a very remote stage, but up to nutrition, these are very primarily and important one, which will contribute, which will help in getting the good prognosis. The pharmacological treatment there are various drugs. Now after this lecture, as I told you, second year will concentrate on all the mechanism related to this, and the fourth year will go for various guidelines, because pathophysiological or basic disease related information was same. So pharmacological treatment, the fourth year may get revised now. They can study at home with for details, but because detailed pharmacology I'll be explaining to second year from the next classes. Here what is there, that is pharmacological treatment. The drugs that increases dopamine content, example is levodopa. Then we combine levodopa with dopa decarboxylase inhibitors. Their reasons are there. I'd like to ask fourth year if anybody knows why these dopa decarboxylase inhibitors are combined with this levodopa, why carbidopa or benserazide they are combined. Anybody knows? Okay. In the meanwhile, the next drugs are MAO inhibitors, most widely preferred one selegiline. Then COMT inhibitors, entacapone, tolcapone, and entacapone is a newer one. Then dopamine receptor agonist is bromkriptine. The drugs which releases dopamine, example is amantadine. Cholinergic agonist, sorry, cholinergic antagonist, because it is understood, it is nowadays they are not that much used, but it was observed that whenever this dopamine was getting less, the acetylcholinergic activity was increasing. The imbalance was there in the area, that is in the basal ganglia, and therefore anticholinergic agents which can cross blood brain barrier, they were used. These are muscarinic receptor. Very good, Mansi. Yes. To prevent their metabolism before reaching to brain, this combination is given. Very good. What will happen if the metabolism takes place before reaching brain? Yes. Yes. See, this is what a very simple question. The Mansi's answer, Rima's answer, that way same. To prevent metabolism means increase T-half. But those who are, good student, how it makes different than other people. This is a very nice example. Those who are seeing this chart. Mansi's line, the first line, that is prevent metabolism. So metabolism is prevent is, there is a definitely T half is, because biological half life is increased, because metabolism is happening, therefore T half is there. So if the metabolism is prevented, then it is drug will not show effect. Okay, no active drug will be available. Okay, anything other than this? What is active drug here? Why it will not show effect? Yes, less amount will be available for crossing blood-brain barrier. Yes, okay. Here, which is the drug? Drug is L-dopa or dopamine? Yes, Mansi, it is correct. L-dopa is a prodrug, dopamine is a drug. So, if carbidopa or this benzerazide is not given, what will be the problem? That is, dopamine will not be available, okay, or L-dopa will not. The problem is why L-dopa is given and dopamine is not directly given. If this is so, why don't we give dopamine? Instead of adding drug, or instead of allowing it to get metabolized from levodopa to dopamine, why should we not give dopamine directly? Okay. 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 So there are all these factors are there. Yes, it will not cross blood-brain barrier. It will get metabolized. And one important thing is, do anybody remember cardiovascular system? Heart failure, the drug which are used in a severe heart failure, cardiac accelerator drugs, when pumping is almost reduced, which drugs are used? साहबा पढ़ाई नहीं कर रही हो तुम कुछ? मिथाइल डोपा क्या करता है? इनके अलावा, डिजिटलिस के अलावा adrenaline in extreme cases, okay. Any other? I'll give clue. Beta 1 agonist. Any beta 1 agonist? Mansi, confused? Metoprolol is what? What I told, beta 1 agonist. Metoprolol is what? Yes, Pratima, dobutamine. And along with dobutamine, one more name is usually discussed. Either dobutamine or before availability of dobutamine, this was used and it is dopamine. Okay? Thanks for responding. Okay? So dopamine, now you can check through, you can go through. So dopamine is, so if you give directly dopamine, then what effect you will get? The person will have cardiac arrhythmias and other effect is one thing. Second thing is, dopamine is a water soluble, will not cross blood brain barrier, already I told you. Third important thing is, this dopamine is a precursor of adrenaline, noradrenaline, we know it. So there are chances at certain places it will be converted into adrenaline, noradrenaline, and will act in periphery. So we'll get, this is what benefit we are having with carbidopa and this other dopa decarboxylase inhibitor, peripheral dopa decarboxylase inhibitor, that whenever it is there in periphery, it will not be converted, this L-dopa will not be converted into dopamine, and whatsoever peripheral effect the dopamine that can show, that will not be there. Okay? This is all pharmacology topic actually, which I'll deal when second year will be there, but I just wanted to get it revised with you people. So it is very mandatory, it is compulsory always to give carbidopa or benzodiazide with L-dopa. So these are the reasons. I hope you understood the reason why we have to combine. Then other drugs, I told you, drug releases dopamine, cholinergic antagonists like benzatropine, hexaphenidil, or that is also called as a proclidin, then piperidine, ethopropazine. These are various antihistaminic agents. Why they are used? Because they too have some anticholinergic activity. As such, histamine is not having any big role over there. So these are the effects which are there. So what is our this one? What we are going for in fourth year? What we'll do? So what are our aim? What are our goal is? To diagnose it as early as possible. Then go for the treatment. There are various drugs are there, levodopa, various dopamine agonists, just now we have seen, or MAO inhibitors like rasagelin, silegelin, etc. These are various drugs. Then check it, go for maintenance. Depending on, again we shall see various guidelines, and accordingly these are very briefly made. Then one can try for entacapone or stalvevo. Those who are in fourth year, I'll like that they should have various adverse effect of various drugs which are used. Whatsoever drugs are used in Parkinsonism disease, because what are their adverse effects and what are the remedies for this, or what can be the alternatives. This is very important, because we have to give this drug for almost lifetime. Okay, so what are the consequences of these drugs we should be knowing about? So please go through various drugs, their adverse effects, what are the adverse effects are there, what are their good things and what are the bad things. You just have a small table like thing, you can submit it as a assignment if you wish, because if you submit it, then at least because of that you will revise it. So you make the list of drugs, their good effect or positive things, and bad things or adverse effect or negative things. So you make that table, that will help us to select them and to make them in our what we can say preference cycles. If you remember, we have seen evidence-based medicine, as we call it as it. So these evidences are there, how beneficial it is, and what is the benefits to risk ratio. We have seen it earlier, it should be highest one. Then in complex cases, we can have drug like amantadine, apomorphine, deodopa, and deep brain DBS is a direct electrical currents are applied to particularly that area, so that it will release the neurotransmitter, that is called as a deep brain stimulation. So these are there, these are the cycles. This is important for the therapeutics point of view, that what we need is early diagnosis. Once we understand about disease, we staging about the disease, what stage it is and what are various issues, then we can provide various kind of help. Then we can try for this treatment, so that, and maintenance of it, so that normal function we can try to continue, so that we can reduce the further degenerations. And regular reviews. Red flags, here word is there, red flags means if we get any kind of problems or adverse effects related, adverse events we call them. So if it is there, then what is support, continuous inputs from the therapeutic monitoring. Then we'll check about whether complications in complex cases, motor complications, etc., etc. And palliative is word use is particularly in cases where they are almost reached to a stage where no further better thing is possible, or it may not be able to improve much. Then we call it as a palliative. Usually is used in a end stages conditions. So where our more concern is there to give good quality of life to that person in the end, instead of harming. Example, if the person is in having a cancer, so at the end, when somebody knows that now it is almost difficult that one can save the person, then the action becomes palliative. Palliative means with having minimum difficulties, minimum sufferings to the person. So this will be the palliative conditions in these cases. So what will be the side symptoms, what are the side effects, what can be the advanced care needs, these all things should be taken care of. So as we have seen, it will become with the diagnosis, patient education, and various this therapeutic guideline inputs are there. Discussion when and which drug should be there, again depending on the guidelines, considering conditions. Example, bradykinesia dominated disease may need earlier treatment than the tremor dominated disease. So if it is tremor, then maybe okay, one can wait for some time. People with suspected Parkinsonism should be referred quickly and treated and sent to a patient, this specialist at earliest. So these are the classes what we have seen earlier. The drugs which are to be avoided, they are very important, because they may affect overall outcomes and they may contribute in the adverse effects. So like prochlorperazine, metoclopropamide, flufenazine, perfenazine, flupentixol, these are the drugs. Then chlorpromazine haloperidol, perfenazine. We know all these because of their action on the D2 receptor, direct, indirectly. Cimetoclopramide, perchlorpromazine, they are D2 antagonists, and they are particularly peripheral antagonist, or we can say enteric one, and they are used in used as antiemetics. Okay, these are used in the depression, that is fluphenazine, perfenazine, flupentixol. Then chlorpromazine, etc. These all are drug we know. We call them as a typical antipsychotics. Yesterday we have had this word to what we call it as a this extrapyramidal syndromes. So we know that they are responsible for these extrapyramidal syndromes. So how the drugs are to be managed? These drugs, all the drugs are having different responses. The treatment regimes will be differ from person to person. The timing of drug is important in order to achieve the good dopaminergic stimulations. Then support nursing and other staff should be needed good, so that patients are managing during this complex. No drugs in all CNS, it is very important. In CNS and most of the hormone conditions, one cannot sudden discontinue drug. So it should not be sudden discontinue, should not be the same thing we have seen in epilepsy, same thing we have seen in various depression, schizophrenia, etc. This drug should not be immediately stop or suddenly stop, or it can stop in the neuroleptic malignant syndrome. Then this national health missions are there. They are having various schemes or initiatives in this is for in other country. So this is what we should do. It should be slow and low, means treatment should be slow, and the minimum possible treatment, minimum possible dose of the drug should be given. Watch for the side effects like low BP, orthostatic hypotension, etc. Then these neuromuscular syndromes, they are more common in older patients. Check about it. They are often confusing and poorly recognized. Then all other signs are there. And lastly, the thing is, patient is expert. That means patient knows many things. Patient knows in the sense not about disease, but about own condition, how much it is improving, etc., etc., and slowly take the patient in confidence, so that the treatment can be in better one. So this is where we have finished the primary one. As I told you, fourth year student should just revise various drugs. As I told you, they may just make the note about pros and cons and the doses of the drugs, various drugs which are available. Then we'll go for guidelines. Hardly one lecture I think we'll need for these guidelines. And second year we'll go for pharmacology of the drug, that is what are various drugs, what are the mechanism of actions, and various pharmacokinetic, pharmacodynamic, toxicity related features. So I hope you understood this. If you have any difficulty, you can put on group, you can ask me, and we can have discussions on this. So take care and be safe.